We're now ready to start session 3, which is looking at the issue of moderate acute malnutrition in infants. And session 3 is going to be chaired by Marco Kerak. Marco is a UK-trained medical doctor who initially specialised in paediatrics. He first became involved in malnutrition in 2003 whilst working at the College of Medicine in Malawi. He says one of the best things that ever happened to him professionally was that his money ran out for his PhD, and it forced him to shift his research focus and then got a job as lead researcher on the original MAM project, Management of Acute Malnutrition in Infants. So that's why Marco is here, because his money ran out and he had no. From September this year, Marco will join the London School of Hygiene and Tropical Medicine with Ricardo and Anne and Claire and many others in this room as the course director for the Masters in Nutrition for Global Health. Marco is of Serbian heritage and enjoys spending his spare time on a traditional Yugoslav folk sport, tennis. Though he can still beat his 2-year-old son, his 7-year-old daughter, he is struggling with his tennis-mad 9-year-old son, whose idol is Novak Djokovic. I think in years to come he'll come to see you as an idol, Marco, but you have to bear with him.
Great. Thank you very much, Lola. And also just want to say thank you very much for the organisers for allowing us to have this session on infants under 6 months. It's very much the new kid on the block, and it's really been exciting over the past years to see things develop. And I want to say also thank you to you, the audience. You can see who the hardcore are who are still here at the end of an action-packed first day after coffee. So thank you to you. We hope we have a good session lined up for you. So first it'll be Marie and myself going through the history. We'll have a clinical quiz in there for you, a poll, and then we'll leap on to some exciting evidence coming from Kenya. And for that, we again invite you to be inspired and to be collecting similar data, thinking about, can you do something similar in your setting? We need different things, make things more generalizable. And then to end, we'll have a presentation about program-related skills from Bangladesh. And again, the big call and the big theme running through this session, I hope, is that when evidence is lacking, we still need to act. We can't say we don't know what to do and do nothing. We need to do something. We need to do the best we can. And for that, we need to communicate. We need to network. We need to share experiences. And we need to move forward as best we can and build the evidence base over time. So going on to a bit about the history. So as Lola said, I first got involved in this in 2008 as the lead researcher on MAM. And we'll just recap some of the key background features of that. And the 3 messages we'd like you to take away from this presentation is firstly, that infants do get acutely malnourished, and this matters. Secondly, about building evidence, GRIP, getting research into policy. If we're struggling as health professionals to come up with recommendations, we can imagine how people in the field are struggling. So sometimes we need to deal with what we have, make the best of what we have, and make recommendations which are plausible, which are a step along to where we want to be. And it's been exciting, especially over the last year, to see the new WHO guidelines incorporate elements of severe acute, incorporate infant SAM. And we hope to argue that these are also very, very relevant to infant MAM. And thirdly, Marie will talk about future plans and how there's a real need for lesson learning networks. And for these, we really need your support and your participation, and to be sharing data, sharing experiences, and helping us move forward as a nutrition community. A background reflection first. It's that the right relationships are vital. I think so often we see infant MAM or SAM as the problem. And what I've very much been feeling as time's gone on is that it's a symptom, not a problem. And the real problem is really relationships which aren't working well. And that can be relationships between practice, between research, between advocacy worlds. Is there some issue in the relationship between the mother and the infant? Are they in turn supported by the father, the family, wider society, employers to carry out key things like breastfeeding? What about the relationships between governments, UN, NGOs, civil society, faith-based organisations, private sector? Are they as good as they can be? Is infant SAM, infant MAM, really a symptom of broken relationships there, not communicating well enough, not working together well enough, not capturing the opportunities that are there? Are clinical medical services working well enough with nutrition services, with other services, disability is an increasing factor? Are we listening to each other well enough? And for me, with my Serbian background, I think this icon sums up beautifully some of the key things here. And it's not just because it's about breastfeeding, depicts breastfeeding. But so often we tend to focus on the infant. And what he's doing, he's focusing on his mother, and he's reminding us, if we want to understand him, we need to also engage with his mother and understand his mother. And what she's doing, she's looking out at us, looking out at you. She's gesturing to him, but she's also inviting you to engage with them. And the analogy is not the treatment for infant SAM, infant MAM, is not something we do to an infant, but it's a relationship we build with an infant, and it's how we can build relationships between the different organisations, different professionals, to really support, to make a difference. So going through some of the key chapters of the report, what we found. So firstly, the background, making the case. And we looked at the burden of disease, and this was published later in the Archives of Disease in Childhood. The prior assumptions, the kind of things that we heard were, children under 6 months, they're often still breastfed, and therefore malnutrition is not a problem. And of course it makes sense, until you start thinking about suboptimal breastfeeding worldwide. So the logic is there, but scratch the surface, and there are some serious flaws. And the implication, and what we were worried about, was if people have this assumption, they don't look for infant malnutrition, and if you don't actually look for it, it's very easy not to see something, even if it's there. So we did look, and we looked at demographic and health surveys. So these were 21 surveys we had from the last 10 years in some of the high-burden countries. And firstly, really to emphasize, these are just rough estimates, extrapolated out to global numbers. So they are estimates, but they're a ballpark figure. And we found that severe wasting affected 3.8 million infants, moderate wasting, 4.7 million. These are WHO growth standards. And we concluded that infant malnutrition is not uncommon, but we do need to consider it. We do need to look for it. We reviewed the current management protocols. And these were a mixture of national and international guidelines. And what we found is that they were exclusively focused on inpatient care of SAM. There was no official CMAM outpatient option for infants at the time. And relevant to this meeting, what you do with an infant who has moderate acute malnutrition wasn't described. There was some inconsistency with the admission criteria. So some focused on anthropometry alone, others focused on clinical features, others focused on feeding. Some had a mixture of all of them. And for all of them, supplementary suckling, so relactation, was the core treatment. There were other things mentioned, antibiotics, micronutrients, supporting the mother, infant and young child feeding. And again, what was notable was some of the newer guidelines tended to be more sophisticated about thinking wider. So that was encouraging. And there were examples of good guidelines which we documented and which are great to learn from. So let's move on. So how should we assess and diagnose? So because it's the last session, a clinical quiz for you. So here's a 4-month-old infant. The mother comes to you and says, yeah, the child's breastfeeding well, not giving anything else, no problems with feeding. You examine the child, completely well, nothing you can find, alert, active, happy. And here's the growth plot. So you've got 4 plots. This is a weight for age, the 50th centile and the 3rd centile, as in most national health charts. And that's the plot you see. So how worried are you about this child? And do you recommend any kind of top-up feeding? Why infants under 6 months? So one of the reasons it's important to focus on them as a separate group is there are important nutritional differences in terms of exclusive breastfeeding being the target diet, IUTF not recommended. Important physiological differences. So they mature very quickly. There are big changes between as the child grows up. Important pathological differences in terms of the organisms they're vulnerable to, for example. And that age really matters. So a 5-week-old is very different to a 5-month-old. And what may be very appropriate for a 5-month-old, it may be completely inappropriate for a younger infant. The challenge is there's a poor evidence base for the current guidance. And there were many questions and challenges arising from the field. So going back to our quiz, so you have another mother who comes to you with the same story. Again, no problem with breastfeeding, everything's fine, going really well, she says. You examine the infant, and similarly, no problem, happy, smiling, looks very well clinically. And here's the plot in this case. So how worried are you here? Are you more worried than the last one? As worried? Do you recommend top-up feeding in this case? What intervention do you recommend here? So perhaps think about that. And then I wonder how many of you spotted that this is actually exactly the same infant plotted on the new WHO growth standards. And it's really important to stress this is in no way a criticism. We believe that the new WHO standards, they're a significant technical advancement, they're a significant opportunity, but they do set the bar a lot higher. And we need to be really careful about not focusing on just the anthropometry alone. That's an important part of the picture, but that's not the whole picture. We need to be thinking, is this complicated or uncomplicated? We need to be thinking, how old is this infant? Like I said, what's appropriate for a 4-month-old is perhaps very inappropriate for a 2-month-old. Big differences, even though that timescale is very, very narrow. And we need to be thinking about acute malnutrition as not a diagnosis in itself. That's not the end point. But what's it a symptom of? What relationship do we need to support? How can we support not just the infant, the mother, the family, and the wider context in which this infant is growing up? So I'll hand over to Marie to go on. And just a quick introduction. So Marie is the co-director of the Emergency Nutrition Network, and I had the pleasure of working with Marie on the initial MAMI report. And I think one of the best things about Marie is her focus on real practical issues and what are the challenges from the ground. Because I think it's very easy to focus on getting the questions technically right. But I think much more important in science is to ask the right questions in the first place. And I think Marie does that brilliantly. So over to you, Marie.
Thank you, Marco. So I'm just going to focus on building the evidence, and as Marco said, ENN is involved because we were initiated the original MAMI project, and so I feel a sense of responsibility for the can of worms we opened with the MAMI project in infants under 6 months, and we're committed to building the evidence base in all its shapes and forms in order to improve practice, and that's what ENN is about, and that's why we're involved. So I'd like to start with making a bit of getting something off my chest, and a plea that as we move forward on MAMI, we really need to broaden our horizons out of nutrition. In nutrition, we love our cut-offs and our classifications, and we carve children up into SAM and MAM, and sectors into health and WASH, and then we get all territorial about who does what and when. And I think we need to really move beyond that if we're going to make inroads, because the real world isn't just like that. Nutrition is important, but it's not just about nutrition. The health care of these infants is critical, and access to health care. In terms of nutrition, breastfeeding is essential, but it's not just about breastfeeding. We have infants who are artificially fed too, and we need means to manage those as well. And it's not just about the infant, it's about the mother. And particularly in infants under 6 months, mothers and infants come as a package. And while this meeting is about MAM, I don't think we should get tangled up in trying to distinguish SAM and MAM in this age group. Much more important, like Mark mentioned, is whether these children are sick or not. And that's a much more important classification. So when we talk about MAMI and infants under 6 months, this is the area that we're talking about, and we're particularly, as a group, focusing in on the 6 weeks to 6 months, because they're in terms of programming, a sort of a no man's land between where neonatology sort of finishes and where lots of our programs kick in, whether they're MAM programs or CMAM, and they kick in at the 6 months of age. So we've got this in between, and these infants, as Marcus said, have a huge range, different developmental stage than older, so they're not just mini children, and so we really need to address their particular needs. We want to figure, how do we identify the most at-risk infants in this age group and treat them appropriately? And we also want to pick up on these infants a bit earlier and stop this decline that we all see as they head towards the age of 6 months. And we also want to see them starting higher up the scale, so at least they have further to fall. This is a huge gap area, and this is where we really need to collaborate with the obstetricians and the neonatologists and the paediatricians. It's not just about nutrition and nutrition interventions. And I think we often see in the nutrition world, and particularly with MAM in older children, a real focus on the nutrition aspects and the food aspects. We need to pay much more attention to health, particularly in this age group. And while this is a gap, it's a window of opportunity for us to really collaborate with each other across sectors and across disciplines to make the most of this opportunity that we now have around MAMI. So in terms of what have we got at a policy level, one of the key recommendations coming out of the MAMI project that Marco mentioned was to have a stronger and more explicit recognition of infants under 6 months in policy guidance and in normative guidance. And we are delighted to see that they're now specifically addressed in the latest WHO update on the management of SAM. And so this we feel is that the guidance and these recommendations are as applicable to MAM infants under 6 months as they are to SAM infants. And what we see in this new guidance is now we see a division between the complicated and the uncomplicated infants under 6 months of age. And previous to this, the focus was all really treating all infants under 6 months that are acutely malnourished as complicated. So it was a real focus on inpatient care. We're now seeing the opportunity for outpatient management and community-based management for these infants. We're seeing also a specific reference to mothers and caretakers and their mental and physical well-being and health, and recognising this. As I just said, we think these are as applicable to MAM as to SAM, and that the complicated versus the uncomplicated division is even more important in these infants. So what the WHO guidance has given us is, in a sense, a licence to explore community-based approaches for managing malnutrition infants under 6 months of age. And when we came out of the MAMI project and then out of the new GAG process for WHO, there was a huge long list of research questions. So a group of us got together and thought we'd try and prioritise these research questions that had the greatest potential to impact on infant outcomes. And we undertook a CHINRI, the Child Health and Nutrition Research Initiative methodology, to help prioritise these research questions, to really help us where to start. So we had a group of 64 experts around the world, did a ranking exercise that is often used in health, and looked at 60 questions. And these are the top 5 that came up. And top of it was, how is infant under less than 6 months severe acute malnutrition defined, which is a fundamental question if we're going to try and actually look at what we're going to do. Other top questions were, what are the key timings for integrating interventions around health? What is the efficacy of targeted scale breastfeeding support to infants who are uncomplicated in the community? And how can we adapt existing tools? So this has been submitted for publication, this research, and we're hoping to hear soon that this will be published. An example of some work that Mark was involved with in Malawi is looking to address this case definition and assessment area, and where they're looking to develop a sort of assessment tool for infants under 6 months of age, where they're starting with a very long list of questions covering these domains like anthropometry, breastfeeding, clinical aspects, depression, and then extra family issues and community issues. By using a long list of questions, we'll be able to see which questions best predict outcomes in infants and try and develop an assessment tool. And then we're also linking in with Save the Children, who are looking to replicate this type of work in Bangladesh. So we're going to also hear later on from Jay and Martha and Roxanna about research and programming they're doing around infants under 6 months of age. And while this is all very valuable work, but we do feel that it's just the tip of the iceberg of what we need to do around infants under 6 months. And we do have a vision of what we would like to see happening. What we've imagined is a sort of MAMI global network where you would have strategic and technical direction to country-based initiatives of research and practice that were organised to inform international policy and practice. And this isn't complete fantasy, but we've been inspired by initiatives in other sectors. And one example what we came across through the MAMI project was the Vermont-Oxford Network, which is a voluntary collaboration of healthcare professionals around neonatal care. And it was set up because of the lack of evidence to guide guidance in this age group. And what they do is they collaborate along data, they harmonise data, they share research and research protocols, and they share potentially better practices, and they work together. And they have 600 neonatal units collectively collaborating on this. So this is a quantum leap from what we do in nutrition in our sector, never mind about MAMI. But imagine the difference that this sort of collaboration could make. At the moment, there's a small group of us, there's a sort of a MAMI working group, that are trying to see if we can make headroads and make this happen, and seeing if we can get funding. So any support you can give towards this sort of initiative, ideas on how to direct it or steer it or indeed fund it, come and talk to any of us. We'll be delighted to hear from you, especially if you have cash. So while we sort of dream the big dreams of where we'd like to go, in the meantime we have to just kind of get on with what we have and do with what we can do. And as Marco said in his opening statement, this is down to you and really sharing and documenting what you can do. We lack direct and strong evidence and research around MAMI, but we have lots of stuff that we can pull on, and we've got very obvious places to start. And so I would really encourage you to document and share what you are doing, no matter how inconsequential you think it is. In our latest edition of Field Exchange, the E&M publication, we have 4 or 5 articles that are around infants under 6 months, just in the latest edition. One of them I've spotlighted here is by Martha and Jay, and it began as an email exchange with a field nutritionist asking us for advice about how to measure infants under 6 months in a survey that prompted a very nice response to her from Martha, which was subsequently developed into an article. So from a little seed, big things can grow. So we would really encourage you to document and share what you're doing. We have also an online technical forum many of you may have come across called NNet, and in the last 2 months we've opened a discussion area for infants under 6 months of age, moderated by the team here. So again, we'd encourage you to advise and also to share what you're doing. And finally, I'm just going to finish with asking for your vote. Within our group, we've been a little bit worried that perhaps MAMI might be seen as a sort of CMAM equivalent, that there's one programming model out there that we just need to crack and that will sort it. And it's really not like that. It's much more complicated. It needs to be much more broader sector. And so we have been wondering whether, in our love for acronyms, whether we do need to change the acronym and have something that more closely reflects the growth, the survival, the development of infants under 6 months that we need to engage, not just on the nutrition and the treatment of acute malnutrition. So we're wondering, do we need to reflect a new acronym that reflects a new phase forward, or do we just need to stick with what we've got but more clearly communicate what it's about? So we've set a little doodle poll up, and we're very delighted if you would go in, have a little vote, make some suggestions of alternatives, or come talk to any of us and tell us what you think. And thanks to the many MAMI people that have been involved, especially to Marco, who's really been a great guy to take the ball and really run with the MAMI work. Thank you.
Thank you very much, Marie. So we've got the link to the poll. So if you like SUNGEL as our acronym, please do vote. And please suggest some other ones, because we need them. What we'll do, we have some questions scheduled now, but if you have a question, could you please write it down and pass it to the front? And we'll save the questions for a big batch at the end. And also just want to thank the people who are helping us make sense of all of this. So Professor Ricardo Oye, who's a Professor of Public Health and Nutrition at the London School of Hygiene and Tropical Medicine, and Professor of Nutrition and Pediatrics at the University of Chile. So he's had a distinguished career and served in multiple expert committees and advised several UN agencies. And what I particularly like about his statement on the website is about he seeks to apply the best science in developing and evaluating nutrition intervention programs and policies. And I think that's really key here. We do need the best science, but we also need to make policy when we don't have much science. And again, picking up on what Jay said, do have a look at Carlos's poster, 117, to pick up on the theme of severe malnutrition of MUAC in infants. And also thank our other rapporteur, Nina Schlossman, who's president of and head of the Global Food and Nutrition Incorporated consultancy in Washington, D.C., which works on global food and nutrition issues. And she directs overall strategy and comes to the role with lots of experience from Africa, Asia, former Soviet Union, and South and Central America. So thank you to you both, and look forward to working together. How do we interpret this? And we will go on now to our third talk. So Roxanna Hyder is the founder chairperson of Training and Assistance for Health and Nutrition, TAN Foundation, and she was formerly advisor for WHO's Southeast Asia Regional Office, and is currently chair of the Civil Society Alliance for Scaling Up Nutrition in Bangladesh, as well as the co-chair of the World Alliance for Breastfeeding Action. And she's particularly recognized for her role in this area, for her dedication to promoting and supporting exclusive breastfeeding and improving infant and young child feeding. So thank you very much, Roxanna. Again, really hope to work with you in the future on next steps for MAMI. And over to you.
Thank you. I must first thank the organizers, IAE organizers, for inviting me, also the MAMI group for including me in their deliberations. And I really look forward to this session as well as to future work. Thank you all for staying. This is the last session of the day. So you're still awake, which is very good. I think you had 2 coffee breaks, tea coffee breaks. So that was a double dose as an incentive. I have very simple slides, and lots of pictures. It'll help you to stay awake. So bear with me. So just a little bit of the background first, then I'll go into the current program and recent findings, challenges, the conclusions, and suggestions. So the background, you've heard a lot about the MAMI project, about what's happening in other countries. So in Bangladesh also, or in Asia, I think, in general, there is a lack of nutritional status data for the less than 6 months in national surveys. And in Bangladesh, what we've been struggling with is child malnutrition rates, which have remained high over the last decade. And as around half the children less than 5 years are undernourished. And the BDH's Bangladesh Demographic Health Survey shows that 41% are stunted, 36% underweight, and 16% wasted. Those are very high figures indeed. Training for management of severe acute malnutrition, SAM, has been provided in several government facilities. You've heard from our colleague from IPHN in the morning about what's happening in Bangladesh. But there are no clear guidelines which have been available as yet for management of moderate acute malnutrition, or MAM, in the 6 to 59 age group, months age group. MAM infants less than 6 months is not documented. Of course, we don't look for it, as Marco pointed out. We have never looked for malnutrition less than 6 months, so it's not documented. Exclusive breastfeeding is suggested for all, but very rarely is any practical help given. Now, the MAMI report, which came out in 2009, had suggested that skilled breastfeeding counseling and support should be provided to all infants, and even those below 6 months, in facilities as well as in communities. But what have we done so far? 5 years have gone. We are still struggling with this aspect. So basically, what have we done since then? I have a background. I was at ICDDRB, worked with diarrheal patients in hospital, helped convert those who were partially breastfeeding, aged less than 3 months, to exclusive breastfeeding, and then moved on to community projects to work with community peer counselors in increasing exclusive breastfeeding. And I have my co-author and investigator, Dr. Anna Ashworth, over here. This came out in The Lancet. And then after that, what happens is when the research finished, the demand came really from the community. They said, such good work's been going on, our babies are healthy, you can't just leave us and go. So please stay with us. So it was a community-led demand, and that led us to establishment of the foundation. And that's where we still are from 2000 to 2014. We're still there working with the peer counselors in communities, in 2 communities. One is in Dhaka itself, the capital of Bangladesh, and the other is in rural Anwara in Chittagong. So what do? We train community-based female peer counselors, and we have adapted, simplified, modified the WHO UNICEF 40 hours breastfeeding counseling course, the integrated counseling course, the AED, and the national training materials. So it's a very simplified course, so that low literacy women can understand and follow the training. The training initially is in the classroom, and it's 4 hours per day, so that they can look after their families, go back and work. 4 hours per day for 4 days, and then for about a week in the community with practical help and supervision. So the counseling visits then that they undertake, the peer counselors, are 2 in the 3rd trimester of pregnancy, 1 within 48 hours of birth or earlier if possible, within 7 to 10 days, and then monthly till the infant is 6 months old. The focus, of course, on early initiation and exclusive breastfeeding for 6 months, practical demonstrations, assistance, and checks for position and attachment, problem solving, a very important component, not just message giving, and most important of all is confidence building in their ability to breastfeed their babies. These are some pictures to show that how they go. The peer counselor goes to the house. If it's a supervisory or monitoring visit, there is a supervisor there. She talks to the mothers. There's regular monitoring by the TAN staff. And there is growth promotion and monitoring every month. So the weights are taken by the peer counselors themselves. For this is ongoing. We have data for all the mothers since 2000 to more from 2006 onwards, actually, when I came back to Dhaka. So for this particular session, then I thought it's better to analyze some data, recent data, look at it carefully. So we looked at the data from January 2012 to September 2013, and saw that mothers and babies who had been enrolled was 740, but we wanted to take just those who had recorded birth weights. So 639 had recorded birth weights, either by the peer counselors or in the hospital setting. Low birth weight cases were 76, 12%, and normal weight was 563 or 88%. Then we looked at those who had completed 6 months of age, and there were about 53% in each of those groups. So now I'd like to share with you some of the photos that we took. And we have permission from the mothers and the families to show this in educational and training sessions, not for public disclosure, so it won't go up on the website. This mother, she's a mother of this boy who was 2 kilos at birth. And at 4.5 months, the baby weighed 6.1 kilo, and she continued to exclusively breastfeed. But you can see that this was an adolescent mother. She's very young. The problem was that she stayed alone. It was a nuclear family. There was nobody around to help her. And she was totally dependent on the peer counselor to help and explain to her how to breastfeed, how to continue, how to look after her own diet. So remember what Zulfikar Bhutta showed in the morning, that adolescent mothers are a big problem, and if we talk about low birth weight, then we have to think of adolescent mothers too. This is a family where it was the first issue of the parents. Again, this is a girl now, with 2 kilos weight, and she was growing well, but not well enough. She could actually do better. She was only 5.7 kilos at 4 months. Problem here was that although it was a nuclear family, the mother wasn't giving enough time to breastfeed. They were very short breastfeeds. And she would just, relax in the house and not really spend too much time on caring for the baby. The father was more concerned. So it's very important to involve the fathers, because then he would encourage his wife to spend a little more time with the baby. This one was another girl. Birth weight was 24 kilos. And here the problem was the mother, that she was diabetic. She was insulin requiring diabetic. And she was very concerned, very depressed why she has diabetes and how she will continue to breastfeed. She was very doubtful in her capability to breastfeed. But the peer counselor encouraged her, and you can see that the baby continued to breastfeed exclusively. At 5.5 months was 6.5 kilos. So then what were the challenges? There were a lot of challenges, and one of this is the perception of insufficient milk. This was very common. And you can see this is the mother who is sitting there with a newborn baby. So actually the baby was only 3 days old. And when the peer counselor's gone there, she said she was just sitting and, putting oil on the baby, massaging the baby before giving the baby a bath. And she looked worried. So the peer counselor asked her, why are you looking like that? Is there anything that you want to share with me? And she said, yes, I don't think I have enough milk. By the third day, she's already saying this. And then there were, of course, lots of neighbors and family members around who said, yeah, she doesn't have enough milk, the baby cries, she won't be able to breastfeed this baby. It's all those negative things that were coming. So we had to then show her, check why she was saying that. And we saw that she was this was her second baby, by the way, it wasn't even her first baby. But for the second and the first one, she had breastfed. But with this baby, again, she was having problems. She had probably forgotten how to hold a newborn baby. She was thinking of the older baby. So for this baby, how to hold, how to feed, we showed her that. And then again, the other thing was how to feed lying down. This was a very important part of breastfeeding. Because for a new mother who's working in the house, she's tired all day with household chores, she needs to rest. Now, if she gets up at night all the time and sits and breastfeeds, then she's going to be exhausted. So showing her, helping her to lie down and breastfeed was a very important thing for her. And later on when we went, she said, you changed my life. You changed my life. I can now sleep at night and breastfeed and get up in the morning and be ready to do everything else. So this is another mother. We come to twins. So twins, not very common, but they do happen to be born. And when it comes to breastfeeding, then they say, oh my, with the ones with one child, they're saying it's difficult, I don't have enough milk. So obviously when there are two babies, you say, how on earth am I going to feed two babies? And here she's already looking tired, she's looking concerned. One baby in her lap, the other's lying on the bed. And she said, when I went at 2 months, and she said that, okay, they were growing well. She was doing exclusive breastfeeding, but she was concerned. She was anxious. And what we saw is that, she said, how am I going to feed? Because I'm feeding one, then the other one I have to feed. So I'm constantly feeding the two babies. I can't seem to manage this anymore. I've done it for 2 months. I don't know how long I'm going to keep it up. So then we showed her. We showed her, okay, how do you do two babies together? And showed her the position of holding, how to hold the two babies together and breastfeed. And she was quite happy with that, and she continued. And then for 6 months, the babies were exclusively breastfed. So all it needed was a little bit of encouragement, a little bit of confidence building, a little bit of hand-holding, and she managed to do it. So that's a very good example. So when mothers say that, I don't have enough milk for one baby, they say, you have two breasts, you can feed two babies together. Okay, so then what were our main challenges that we've been facing all through? Of course, we see there's a lack of skilled health staff to prevent and manage moderate acute malnutrition. What do health staff do? They just advise. They say you must breastfeed exclusively. Some say that, not all, but now increasingly more and more give that message. But they do not check position and attachment. If they do not check if it's wrong, they do not help the mother, they do not show it, they do not encourage. What they do is criticize. and say, you're not doing it right. Why aren't you breastfeeding exclusively? You should do that. It's going to harm your baby. This is a very big problem. They know something, but they don't know enough. They don't know how to counsel the mother. And then, what else? Environmental problems, especially wash problems, water sanitation problems. This is very common. It's unhygienic in most of our areas. And there is frequent illness. So what happens if there's frequent illness? If they're going to the healthcare worker, again they get a conflicting message. What have you given? What did you do? Don't do this, don't do that. And it's also the neighbors. It's not only the health staff. So the mother has to deal with all of these people. Then again, if there is moderate acute malnutrition, there are no referral centers. Or if there are, because now as you heard in the morning that training has been given, there are some health facilities where staff have been trained, but the community doesn't know about it. They don't know where to go. So, and even if they know, even if they're told, they're very reluctant, very hesitant to go, because it means spending time, taking transport, leaving the other children behind, so they hesitate to go. Then, of course, there are mothers' perceptions. What are these perceptions? One you've already heard, insufficient milk, which is common globally. Then, of course, there are problems like baby doesn't want to breastfeed for long, especially if it's low birth baby. The baby wants to sleep. It's better if the baby sleeps. Then I can do all my housework. So they don't wake up and feed the baby. Or if the baby is feeding for small amount of time, maybe 1 or 2, 3 sips, baby gets tired, mother leaves the baby. She stops the breastfeeding. So it's not enough, and her perception is, it's okay. It's enough for the baby. Then there's lack of awareness and belief in the benefits of breastfeeding. They know it's good, but how good is it? What it's going to do for their baby? What is going to help develop? How is it going to help develop the potential, their intelligence? That's something now mothers are saying, that, breastfeeding makes the brain develop. It's good for the child's brain. Every mother wants the children to do well in school. So this is a very catchy point. We said it increases baby's intelligence. So they like that. But many people are not aware, and they think it's okay. If you can give other milk, that's also good enough. That unfortunately has become the norm. Mother's time, of course there's a lot of housework. She's busy with other chores. And she even gives less time for counseling. She's too busy. Then there's psychosocial problems, like some mental depression, problems in the family, husband without a job, or husband's gone off, married another woman, so these things happen everywhere in the world, okay. And of course, marketing and promotion of breast milk substitutes. Never forget, this is always happening at every level, subtly or covertly, it's always there. So what happened then? Despite all these challenges, did they breastfeed exclusively? See the low birth weight, 85% breastfeed exclusively, and the normal weight, of course, 89%. And this is for 6 months. Every month data collection, peer counselors knowing this is what the mothers have reported, and this is what we've got. So they did pretty well. But when we look at their weights, what do we see? That the low birth weight, this group, as you remember, there were only 12% at birth who were low birth weight. But this goes up to, if we are using the Z scores, the weight for age, 22% already by the first month are in that, I have MAM. And this goes up to the last month, 6 months is work, to 35%, which is about 1/3 of the babies. The normal birth ones, normal weight ones, more or less remain around the same. So it's the low birth weight babies who are having the problem in growing. And at what time? It's the first month. Remember, by the first month, they're already 22%. So if you have to look at a time for intervention, for really giving skilled support, targeted, more frequent skilled support, it's the first month. This is something that we need to keep in mind. So what then are our conclusions? Community-based breastfeeding support is effective and it's sustainable. We've been doing this since 2000. We are getting very good results, consistent between 70 to 80%. These are our results. Very high EBF rates were achieved for low birth weight and normal weight infants. But it required frequent monitoring visits and supportive supervision. This is crucial. But despite individual home-based counseling, MAM rates were 3 to 4 times higher in low birth weight infants. So some suggestions in the end. We want to ensure that there is targeted, intensive breastfeeding support for mothers of low birth weight babies, whether in the hospital or they're in the community. We should build or facilitate mechanisms for clinical checks and treatment of illness, because they're frequently ill. Provide appropriate training for health facility and community staff. And this means how to read growth charts, how to interpret them, how to counsel mothers, how to take the necessary action that is required. And of course, the other aspects. Build linkages with programs that impact on less than 6-month infants. And as Dr. Bhutta said in the morning, adolescent health and nutrition extremely important, so we need to go back. Reproductive health, safe delivery, family planning, baby-friendly initiatives, EPI, IMCI, growth monitoring. There are opportunities everywhere and at every step. We need to include fathers and grandfathers in counseling and orientation sessions, because sometimes the fathers are not there, the grandfathers that can take the babies to the health facility. Provide a holistic and comprehensive package of feasible and sustainable interventions and support. And last but not least, more action-oriented research. Thank you very much.
Great. Thank you very much, Roxanna, and thank you for a really interesting, really inspiring presentation, and to everybody for sticking to time. So we now have 20 minutes for questions. So what I propose is that we do the same as last time. So take questions in sets of 3. And just a reminder, if you could please state your name and where you're from. And also, please, could they be questions rather than mini presentations? If you have a mini presentation, join the MAMI network and let's write it up together. So we need those, but we need to get as many questions as we can. So Charlotte first, and then lady here and gentleman just behind.
Hi, Charlotte Wright from Glasgow in UK. This is really a question about the last presentation. I'm puzzled. Those low birth weight infants presumably had a low Z score at birth. So if your definition of MAM is a low Z score, then by definition they already have MAM when they're born. So would it not be more accurate to say that 2/3 of them had moved out of the MAM category? Or are you adjusting for birth weight in your definition of MAM?
Thank you. So that's one question. So we'll come back. We had 2 questions here.
Yes. I'm Esther from World Vision, South Asia and Pacific region. My first question is to Jay. Could you please repeat about the cutoff point for the low MUAC that you use in your research? And my second question is for Ms. Roxanna. Could you please mention some of the examples of the diseases that cause the children to be suffering MAM, even with good exclusive breastfeeding rates? Thank you.
Great, thank you. And then gentleman just behind.
Yeah, I'm Wilson Were from WHO. First of all, thanks for this interesting presentation. For the first, Mark and the team, I just wonder whether looking at MAM below 6 months, is it a problem or is an outcome of a problem? So I think this is something I would like to hear from the group. At that age group, are you thinking that MAM is a problem or there's a problem that leads to MAM? Thank you.
Great, thank you very much. So if we can perhaps start with Roxanna to address those questions. So we had one from Professor Charlotte Wright about aren't the low birth weight infants to some extent already MAM? Then we had a question about cut-offs and what are the underlying diseases, and related to that, is it a problem or is it, I think like we were trying to say in the first presentation, a symptom of another problem which we need to get to grips with? So if we start off with Roxanna, please.
Thank you, Charlotte. Yes, that's exactly it. I mean, what is the definition of MAM? When do we say that these babies are in moderate acute malnutrition? Do all the low birth weight infants come in here or don't? I mean, that is the question that we are asking as a group. So, but they do move out, and that is the encouraging thing. That is what we need to, absolutely, I'm so glad that you pointed it out. It's not only that they remain malnourished, it's that they move out and 2/3 of them improve. So we can do something for them. And it's not only them, it's also the older groups, the counseling, they do improve. Just pure counseling, nothing else. For the diseases, it's just the common diseases that affect everybody else, all the other infants, the normal weight infants also. Diarrhea, acute respiratory infections, pneumonia, these are the common problems that occur. We did not look for morbidity because remember these were the peer counselors who were collecting the information, but sometimes when the babies were very sick, I was informed, and for diarrhea, of course, we'd sent to ICD-DRB, but they also went to other hospitals if they were down with pneumonia or ARI. But malnutrition, of course, was not something that the peer counselors were very conscious of. Ma'am, is it a problem? Is it a symptom or is it a problem? We don't know. It's both, actually. Because if we look at what's happening in pregnancy, or if we look at the young mothers, adolescent mothers, then it is a symptom. It is a result of all that. And it's a cycle. One thing leads to another. It's all interconnected.
I think the issue of cut-offs is quite difficult, actually. I think that the comment that Marie made at the beginning is important, which is the actual problems that the baby's got are perhaps more important than the cut-off for MUAC. What I presented was cut-offs just in 1 centimetre bands, which roughly matched the numbers of children picked by weight for length Z-score, but the children have completely different characteristics. If you were looking at the kinds of children which we were looking at for the post-discharge mortality, I would be rather unhappy having a cut-off which only identified children with a 30% risk of dying before the age of 5. I think that would be too low. But the real question is, what can you do about it, and whether the MUAC predicts children who are going to benefit from an intervention, what coverage you could have for that intervention and how much it's going to cost. So I think in discussing what the cut-off should be, I think the context is extremely important.
Just maybe to add on to what Jay has said, in the data that I presented, the retrospective cohort, we experimented with different cutoffs from what the inpatient data has shown. So we're still experimenting on different MUAC cutoffs, and we're looking at different data sets from different places in order for us to come up with a consolidated cutoff that we can then recommend, hopefully.
I guess just to answer the question about is it a problem or an outcome of a problem, I think it may be both. I think it may be if you're seeing severe acute malnutrition or moderate acute malnutrition in a 2-week-old or 2-month-old, that might be a reflection of a problem in pregnancy, in adolescents, in low birth weight infants. But it may also be, if we take somewhere like Syria at the moment, where there's cases of severe acute malnutrition in infants under 3 months who are not breastfed, and have no support for artificial feeding in that response or in that particular context, then that's much more of a problem here and now that isn't related to pregnancy, but it's related to something very acutely happening in an infant. So I think with MAMI, it's very context specific, and I think we need to always be looking at what is this a sign of and what is this a symptom of beyond just the immediate context of that infant.
Okay, thank you very much for those questions, and I think that really does reinforce this issue that we do need better assessment tools. We need to think beyond just weight for length, about MUAC and other things. So if we move to this side of the room, Professor Gold and Mark, and down here.
Thank you. Wonderful presentations. The best breastfeeding counsellors I've ever seen in the world have been trained by Professor Talukder in Bangladesh. I would like to know what your relationship in ICDDRB with the Mother-Child Hospital of Professor Talukder is, whether the programs are the same or different, whether you cooperate, or whether this is a turf war within Dhaka.
Thank you. This is Michael Freemark from Duke University. This is for Martha and Jay. If I recall your slide correctly, you found no relationship between HIV infection and MUAC per se. And if that's the case, since both increase the rate of mortality, one wonders whether there are significant differences in the pathogenesis of death in the two subgroups, which raises the basic question of why children who are stunted die to begin with, and why patients with AIDS die, and are they dying from different causes. Jay and I briefly discussed this at one of our sessions afterwards, but I'd like your thoughts about that again.
Great, thank you. And we had a third question down here.
Hi, my name is Elizabeth Duxbury. I'm from the University of Wisconsin-Madison. There's been a lot of discussion about the different approaches to prevent MAM from infants to adolescents. As a student soon to be in the professional world, what is your suggestion of the most important initiatives we should take to fight and prevent MAM?
Great, thank you. So, and could I also point out we have Dr. Slukster in the audience as well. So, so we have Dr. Slukster somewhere in the audience, so comment on that. And I think for a country with 150 million, that's actually stolen my thunder a little bit on the wrap-up. But I think there's scope for lots of work and lots of inspiring organizations. So if you can perhaps start with Roxanna again.
Dr. Golden, Professor Talukdar was also my teacher, and I've been trained, I'm part of his team of trainers. So, so with all due respect, we carry on the work, and I am no longer at ICDDRB, so maybe Tamid and his team can talk about what they're doing. But whatever we're doing in the field, we're very much following the same guidelines. There is no turf forward.
I think I rushed over that bit of the talk, but there was a very strong relationship between MUAC and HIV status, and a very strong relationship between MUAC and weight for length Z-score status, and the two lines looked very similar. What was different, and I didn't go into detail, was that when you included HIV in the model of post-discharge, most of the effect of weight for length Z-score disappeared. It seemed that weight for length Z-score picks up the effect of HIV much more closely than MUAC. So MUAC remained with a very strong independent effect of HIV, whereas HIV mopped up a lot of the effect of weight for length Z-score.
Great, thank you. Any comments on the third question about prevention of infant MAM? Yeah, Lola just whispering there's no magic bullet, no easy solution. So, but I think that goes back to the question of linkages, and we need to work together thinking about maternal nutrition life cycle approaches.
I think that there are two aspects. One that you mentioned, that the present curves from WHO are very demanding for the breastfed infant. And in fact, that has been brought up by Dr. Cattaneo. And the raw data that Mercedes Leonis has produced is that those mothers had very high milk output. So I would consider that the breastfed infants, according to WHO, are really not representative of the true population. And you will be underestimating the breast milk or overestimating the growth failure if you use exactly the curves as they're used. And that's been written up by Mercedes and recognized. It's very important that everybody be aware of that. The other point I'd like to make also, and you mentioned this, is that somehow the low birth weight baby needs to be separated into the small for gestational age and the preterm. And the preterm needs to be adjusted for gestational age through the first month of life. Otherwise, you will be overestimating your malnutrition. So the point that you've made, that the preterm baby in this data are not separated, I think you need to separate them, because otherwise you will be overestimating the malnutrition. The SGA, on the other hand, is a true intrauterine malnourished, and those infants need to be catching up towards the norm, again adjusting for gestational age. So the interpretation of the norm needs to be adjusted for the birth status in terms of gestational age. Otherwise you will also be overestimating mom.
Thank you. So that really reinforces yet again that point about assessment, and it's not just the anthropometry. You need to be thinking about the clinical picture, the wider family picture, and what are the underlying causes. And thank you for that. Can we take some questions maybe from the far side? So gentleman in the blue shirt at the back, and then Carlos and the lady here. So
This one goes to Roxanna. I wanted to know how you keep these peer counselors motivated, or what strategy do you have to keep them motivated so that they participate in the program?
Thank you.
The
Really
other one was
important
also
question.
concerning the support. Who is supporting this program? And maybe through the last one is what explains the existence of MAM 3 times higher in the low birth weight babies.
Thank you very much. Again, important question. Carlos?
This is a question with regards to MAMI as a whole. I mean, it is very clear that MAMI, to a large degree, was born to cover an operational gap of children under the age of 6. But my question now, over the age of 6 months, my question now is like, what's the value of sticking to that formula of children minus 6 months and not extending, for example, of children minus 7 months or up to 1 year? I mean, why are we still focusing on that cut-off value?
Thank you. And the lady behind you.
Thank you. Helen Semo from the Ministry of Health, Tanzania. It's good to be precise, especially in anthropometric measurements for infants in relation to mortality. But taking into consideration the human resource for health crisis, the equipment and competencies at our settings in low-income countries, wouldn't presumably the infants were born with low birth weight. Wouldn't weight gain be enough as a proxy indicator to do the monitoring? That's the first question. The second question, wouldn't the measurement be better taken, this one is concerning the community health workers. Would the measurement be better if taken by a competent facility-based health worker compared to the CHW?
Thank you very much for those questions. So we had one about motivating peer counsellors. The second one, where do we stop? How do we define our target population? And thirdly, about how do we monitor, is growth enough? And about the practicalities of measurement. So should we start off maybe with Jay and Martha first?
Okay, I'll just start with the question on community health workers and what we found. When we did this experiment, we actually invited 3 cadres of staff. We started with an expert anthropometrist, and we defined this as somebody with vast experience in anthropometric assessment. This was, we recruited a lady who had 32 years working in the Kenya Medical Research Institute as an anthropometrist. Yes, they do exist. And then we wanted to get a proper practical gold standard for which to assess the remaining cadres. So the expert anthropometrist did some repeated measures, and we recorded the intra-observer reliability for that. And then we also recruited nurses, which is what you're alluding to, nurses, and we also recruited public health workers, public health officers who would actually be the ones training community health workers in our setting. So we assessed the reliability because we needed a proper gold standard for the community health workers. And what we found is that the health professionals, as you call them, performed worse. And I think the reason, when we probed further, we found that the reason was attitude. They are not as keen as community health workers because they feel trained and professional, and they do this all the time anyway. So even after taking them through a day session, they felt, what are you showing us? We know this stuff. We go out there and do it. And so they didn't do very well. We've described all these findings in the paper.
Great, thank you. Roxanna, about the motivating health workers?
Peer counselors, yes. Well, I think this is a tough question because I've always been asked how they remain motivated, and I think the motivation, the passion is transmitted from me to them somehow. So that's one thing. But we do give them an honorarium. They work for half a day, and we pay them what normally an NGO worker would be paid. If an NGO worker gets paid for 8 hours, then we pay the peer counselor for 4 hours accordingly. So it's the same scale. But the advantage is that she can go home, she can look after her children, she can do the cooking, she can do all the household chores and look after her children's education. So many of these peer counselors just want to do that till they are more trained and they are more confident, then they move on to another job which might pay more. So that's one thing. And you asked for who supports them. Basically, it's the TAN Foundation itself, the patrons of TAN who donate funds for this program. It doesn't cost a lot, but it has substantial costs. And then in between, we have received small grants from WABA, World Alliance for Breastfeeding Action, for some activities, then from the World Bank, which was also a grant, competitive grant, where we worked on complementary feeding to see whether peer counselor would also increase complementary feeding. So those were the two big grants that we have received, but most of the time it's just the TAN patrons who are continuing to fund. Thank you.
Thank you.
Why 3 times higher? I really don't know. That was also another question that you asked. What happened? What was the problem? We could not go into so many details because remember, this is not a research setting. This is program. I'm talking absolutely from grassroots level, from program. Peer counselors are collecting data. The supervisors are checking on them, monitoring. We do compile data, we enter it, we analyze it, because being a researcher, I'm very careful with the quality, but we cannot go into details of what illness or what problems these babies were having. I'd love to do that, but of course that would need more funds. Thank you.
Great, thank you. And then the last comment, Marie, about how far do we go?
You're right, Carlos. It did start off as an operational gap, programming gap, which still exists. And what's sort of a defining characteristic of infants under 6 months is the exclusive breastfeeding, and there's so much attention and investment and brains thinking about children over 6 months of age. So I think that's why we've retained our focus on the under 6 months of age. It doesn't mean that initiatives and work that happens there doesn't apply to the older, and that would benefit older children. And we can certainly have that transition and that grey area between the two. But that's our focus, and that's why we've retained that focus.
Great, thank you very much. We still have just a few more minutes, and we had 2 ladies here to wrap up. So your questions, please.
First, I have to thank you for looking at this direction at last. My name is Lynn Moeng from South Africa. I may be asking a slightly different question because of the setup that we find ourselves in. We have a lot of mothers with babies below 6 months who will not breastfeed because they leave their babies with grandmothers. Now, you find yourself in a difficult situation should this child be admitted with MAM, because one, you can't relactate for a mother to continue breastfeeding. There are no RUTFs for children below 6 months. So the question, what are people using in other countries? What guidance can we get for children below 6 months who have MAM, who need to be fed? And in most cases, they were formula fed, hence the child ended up with MAM because the formula was either poorly prepared or whatever. So what guidance can we then give parents of such children?
Great, thank you. I think that's a great question, and I think one that lots of us struggle with, about how do we support those whose mother is away for whatever reason. And the lady next to you for the final question, please.
Josephine. Global Nutrition Cluster. Yeah, my question is, I guess it's something that I'd asked before, but basically looking at the various studies and operational research, it seems obvious that a lot is happening in terms of researches and so on. But how is this coordinated in such a way that this can influence policy and guidelines? I asked the same question before, and my colleague from Tanzania, my East African brother, said it's government responsibility. But we also know that a lot is happening out here. How do we ensure that this is coordinated so that we are able to systematically influence policy? Marie, you did mention that the MAMI research was finally able to influence the WHO guidance. What were the steps to ensure that that happens? Because I can clearly see there's so much out there. And initially in the morning when we talked about, the presentations made, it was very clear that there are these gaps. Some of the researchers do not have this, the quality is this and that. Who ensures that that quality is there so that what we do truly can influence, policy and guidance? Thank you.
Great, thank you. So, two important questions. How do we support infants whose mothers are absent? And secondly, what's the process by which we can influence policy? Who wants to take those?
It's a very good question about artificial feeding, and I think I just touched on it when I did my presentation about some infants aren't breastfed, and we need stronger guidance about how to manage those infants. And I think often we see infant formula as something from the devil, but it is a breast milk substitute, and sometimes it's necessary, and sometimes the management of those infants is about minimising the risk of artificial feeding. It's not about advocating and trying to push breastfeeding in those cases like you're describing, and that needs to be part of the whole conversation and part of the guidance. And there are some materials that do exist for management of acute malnutrition in non-breastfed infants, which I'd be happy to share with you. And I'm glad you picked up on this, Josephine, about how we coordinate and have quality research, and that the left hand knows what the right hand is doing in this sector. And that comes back to this MAMI global network that is our vision. Because I think we need to not just dwell now on what are the gaps, what do we know, what we don't know, but how do we fill those gaps in a sensible, quick, coordinated fashion that isn't wasteful in terms of time and resources. And Marco mentioned that Mammy's sort of the new kid on the block, but after the new kid on the block becomes the cool kid on the block, and suddenly there'll be money, and suddenly there'll be lots of agencies going off doing lots of different research that isn't coordinated or isn't designed in order to be able to inform research and policy. And that's what our vision is, about having a network which does collaborate on research methodologies and which does allow that coordination between agencies and governments. But you need to actually invest in this and to make it happen, because I think we have a real tendency towards disorder in our sector, and I think we need to invest to at least have some organised chaos about what we're doing. And that's why we can talk and chip along, but I think we really do need to get some investment in the coordination of this sort of work, which we have failed to do in so many arenas and domains of nutrition. And this is an area that is quite a gap area, and therefore we can actually for once try and do it right. So I think it's a really good point.
Can I add to that? I think in the under 6 months we're at a stage where we're still trying to find out what's going on and even how to define the problem. And I think that there are a series of steps to go. But the important thing is that we go fairly quickly to doing really high quality evaluations of interventions to try and either prevent or treat the problem. And I think that the responsibility for making sure research is of a high quality is you guys. I think that you should be critical. I think you should be very critical. And I think you should be engaged. And I think you should tell us researchers what your questions are, what your needs are. And it's about engagement. If you look in other fields of child health, for example, a meeting like this is very much where people would be asking, searching questions. Why did you design it like that? Why didn't you have this kind of control group? Why didn't you do it randomised? And Rebecca's talk earlier today was very helpful in people seeing that there are different approaches to answering questions. But I'd urge everybody here to be engaged and critical.
Roxanna or Martha?
Yeah, I just wanted to add to the question on relactation and RUTFs and all that was asked from South Africa. Yes, I'm addressing your question just briefly to say that we're still at the stage where we really don't know what to do with most of the infants that we find. And but we're at a good position because at the moment, with the upgraded guidelines, there are some suggestions as to what to do. And I would like to support what Marie has said, that sometimes it's about managing the risks of whatever feeding feeding schedule that the infant is in. So moving forward for myself, for example, as a scientist, I'm very intrigued by what WHO has proposed. And there's a lot of discussion if you read the updated guidelines, and they discuss a lot about relactation and mention a bit about possibilities of RUTF in this age group as well. So as a scientist, my job becomes investigating the effectiveness of those interventions, and I'm interested in looking at exactly what you have, the dilemma you have cited moving forward, but I wouldn't say that we do have a straightforward answer.
Thank you, Martha. Roxanna, any last thoughts?
No, just for the non-breastfed, we were very fortunate. At least in this data set, none of the babies were non-breastfed. They were all breastfed. Some of them moved to partial breastfeeding, as you saw, but there were very few. Those who do choose later on become non-breastfed after 6 months usually, and even that percentage is very small. But we do suggest and advise and guide them on how to use whatever else they're using, whether they're giving other milk or, but after 6 months, of course, they start solids. So how to give the other foods, that sort of guidance is continued. We don't drop them. But it's luckily, we've been fortunate. We haven't had this as a major problem. Thanks.
Great. Thank you to everybody. We're just in the last few minutes. So just 3 quick wrapping up thoughts from myself. And these all relate to gold standards. And the first one is about the WHO growth standards. These are gold standards for infant growth, and they do set the bar quite high. But we need to see that as a great opportunity to move forward, to support as many vulnerable infants as we can. And we need to think about how do we assess them, what indicators do we use. I think Martha and Jay gave a great presentation about gold standards for high-quality operational research. And certainly for me, that data from Kenya is highly persuasive. But we've had at several meetings, people say, yeah, that's great for Kenya, but we need more data from elsewhere. And so we'd really like to call on yourself, the audience, to have similar things from other settings so we can generalize, so we can move forward with that all-important assessment from other settings, from other countries, Africa, Asia, from stable settings, emergency settings. And lastly, I think Roxanna set a very high gold standard for the kind of support programs that are possible. And certainly that's one thing, and thank you for picking up on that, Professor Golden, that's very doable when you have inspiring leaders, inspiring teachers, inspiring individuals like Roxanna. But how can we scale that up to a country of 150 million, one country, let alone all the countries that need that kind of support? And I just end with a final thought. It's about networking and the issue of how do we influence policy. I think one reason why things have moved fast in this field is because we've had great policymakers, and I want to thank Zita, Nigel, WHO for having MAMI as a topic at the recent UGAG. And that, I think, is not to be underestimated, the importance of having people who are looking ahead and thinking. I think if it gets to questions when people are presenting research, critiquing research, then arguably it's a bit too late. And one thing I've increasingly been reflecting on is that we need to be working in the beginning, when we're designing the research, working together then to ask the right questions which will fit the policymakers' needs, which will fit the needs of those on the front line. So if we can work together in the beginning, we're a lot more likely to succeed together in the future. So thank you all very much and wish you a good evening. Thank you.
Huge thanks to Marco for wonderful chairing. Thank you.